Morning to each and everyone. At the outset, I would like to thank Professor Pradeep Sharma sir and AIOS office bearers for giving me this opportunity. I would have loved to physically attend this DreamCon 2022, but I could not be there because of being recently tested COVID positive. I'll be talking on management of sixth and fourth nerve palsy. Now, what are the signs and symptoms of sixth nerve palsy? It presents with horizontal diplopia worsening towards the affected size. There could be a phase turn, and the measured esotropia would be concomitant, that is greater in the field of action of the muscle. Now, this is a case of acute onset post-traumatic diplopia. So what we see here is a very good morning to each and everyone. At the outset, and what is required is just observation and follow-up as most of these cases can recover with due course of giving me this opportunity. This is another case of 34-year-old male presenting with sudden onset diplopia, with headache on and off, with occasional. A very good morning to each and everyone. At the outset, I would like to thank Professor Pradeep Sharma sir and AIOS office bearers for giving, as most of these cases can recover towards the affected size. There could be a phase. Would have loved to physically attend this DreamCon 2022, but I could not be there because of being recently tested COVID positive. I'll be talking on management of sixth and fourth nerve palsy. Now, what are the signs and symptoms of sixth nerve palsy? It presents with horizontal diplopia worsening towards the affected size. There could be a phase turn, and the measured esotropia would be concomitant, that is greater in the field of action of the muscle. Now, this is a case of acute onset post-traumatic diplopia. So what we see here is a left eye traumatic sixth nerve paresis, and what is required is just observation and follow-up as most of these cases can recover with due course of time. This is another case of 34-year-old male presenting with sudden onset diplopia, with headache on and off, with occasional vomiting. There is no other history of any other neurological illness, and there's bilateral abduction limitation suggesting bilateral sixth nerve paresis. On examination, his vision is absolutely fine. The anti-segment is absolutely normal, but what we see is a large papilledema, and the neuroimaging suggests that there is a large intracranial space occupying lesion. So dilated fundus examination is a must in almost all cases of recently acquired sixth nerve paresis or sixth nerve palsy. Now, management options during the acute phase, you can think of occlusion, prisms, and botulinum toxin. 6 months later, when the misalignment stabilizes, we have to plan for surgical correction. For partial sixth nerve palsy, one can plan MR recessions, LR resections, RNR, and RNR can be combined with contralateral recessions. This is a case of left post-orbitotomy sixth nerve palsy, and the patient undergoes a recession resection procedure, and we can see there is a pretty good alignment post-surgery. For total sixth nerve palsy, we have options of partial VRT with MR weakening procedures, or full tendon VRT with MR weakening, or we can also have muscle union along with MR weakening. Now, there are a lot of published procedures like Hammershim advocated partial VRT of temporal halves, O'Connor advocated full tendon VRT with LR cinching, Carlsel and Jampowski advocated adjustable partial VRT, Jensen advocated muscle union procedure, Kushner modified the Jensen's procedure to middle halves. All these union procedures can have problems of strangulation of vessels. To overcome this, Rosenbaum advocated full vertical recti transposition with Botox, and Foster advocated full VRT with lateral fixation augmentation suture, or the Foster's suture. The newest in the literature is the Nishida's procedure. Originally, it was described along with a muscle split. Later, the muscle split was avoided. So what we do is the temporal halves of both the superior and the inferior recti are transposed to the lateral rectus. Now, this is the original, this is the modified Nishida's procedure, where the muscle union is to take place approximately 8 mm from the insertion and 10 to 12 millimeters radially, midway between the superior lateral and the lateral inferior rectus, and there is no splitting of muscles. Now, we can add adjustable medial rectus recession to make the Nishida's procedure adjustable. This is the case of left post-traumatic sixth nerve palsy. The patient undergoes large MR recession with half-width VRT of superior and the inferior rectus to the LR, along with the Foster's augmentation suture. And we can see there's a good cosmetic alignment. This is another case of right post-traumatic sixth nerve palsy with diplopia and primary gaze. The patient undergoes medial rectus recession, which is adjustable, along with the superior rectus transposition procedure. A post-viral sixth nerve palsy involving the left eye, the patient undergoes left eye MR recession with superior rectus transposition. Again, we can see the good alignment in these patients. Botox can be used to manage the acute phases of sixth nerve palsy. This is the case of left eye sixth nerve paresis, where Botox has been used to alleviate the symptoms of diplopia. Now, in acute phases without disc edema, observation can be followed. In children, if there is no neurological sign, they should be examined every 2 weeks till full recovery occurs. If it is persistent for more than 3 months, neurologic evaluation is a must. For young adults between 15 to 40 years of age, look for the risk factors. For patients who are more than 40 years of age, rule out diabetes, hypertension, atherosclerosis, and other systemic conditions. These patients may recover fully, especially with diabetes and vasculopathy. Patients with increasing esotropia, developing neurological signs and symptoms, a detailed evaluation is always a must. Now we move on to fourth nerve palsy. Fourth nerve palsy is one of the common nerve palsies seen. It is usually congenital, post-traumatic, post-viral, ischemic. It presents as a head posture, which is usually a tilt, asthenopia, vertical strabismus, or diplopia. It is never a sign of raised ICT, but may be associated with diabetes and hypertension. This is the NAPS classification with respect to the right eye. So if there is a maximum involvement in the levo elevation, right inferior oblique recession is to be planned. That is because we are trying to tackle the overaction of antagonist. If there is a greater deviation in the field of action of superior oblique, that is maximum involvement of the levo depression, then right superior oblique tuck with right inferior rectus recession can be done, or a modified Haradato can be planned in these patients. So we have to plan according to the type of involvement in the 9 gazes as outlined by the NAPS classification system. Try and suspect bilateral sixth nerve palsy if the patient has a history of concussion or closed head injuries, if there is a V pattern, chin down position, alternate hypertropia or alternate head tilt, and the objective torsion is more than 10 degrees. There can also be sometimes subjective complaint of torsion. Now, what are the management options in case of fourth nerve palsy? For congenital cases, plan for surgery. For acquired, during the acute phase, occlusion can be given to avoid diplopia. Botox is not a good choice. 6 months later, we can plan for a definitive management in terms of surgical management. Park's 3-step test is an important test to find out the underacting cyclovertical muscle. So in this case, we have minimum left over right, that is the L over R on examination. And this L over R aggravates on dextro elevation. And this further aggravates when the patient is tilting the head towards the left. So we can clearly see this L over R aggravates in the left head tilt. So it's a case of left superior oblique palsy. A 17-year-old male presenting with tilting of head towards the right side while working, and it is seen since childhood. So we can see there's a slight L over R, with L over R worsening in dextro version and also on dextro elevation. So this is the Park's 3-step test for this patient. This is slight L over R, it worsens on dextro elevation, and it further worsens on the left head tilt. So it's a case of left inferior oblique palsy where left modified dilated Nankin procedure was done for this patient. And this is the post-operative photograph, which is showing you a very good alignment. And this is the Park's 3-step test or the head tilt test where we can see that L over R is gone on the left head tilt. Now this is the torsion, which is markedly improved. This is the preoperative and this is the postoperative torsion. This is another young boy with left superior oblique palsy where we can see there's a marked L over R and there is a gross underaction of superior oblique and the maximum involvement is seen in almost all dextro versions. The patient undergoes superior oblique tuck and this is after 3 weeks. We can see there's slight development of Brown syndrome and this Brown syndrome gradually improves and the patient gets a relatively good alignment. So in the end, I just want to say that careful assessment and proper choice of procedure is key to success in paralytic strabismus. Thank you for your kind attention.